So morning everybody. Yesterday I think was a quite good example of the utility of ADR. There's still quite a lot of skepticism, I think perhaps, which is in the long-standing sort of old, perhaps I would say the more traditional CTO community, so that which is generated from the sort of Japanese movement. And over the last 10 years, we've had quite a lot of, there's been a lot of pushback and challenges about introducing ADR as I think, a routine part of our CTO armamentarium. So I think it's worth going over what we would now consider what are the exact indications for ADR, where does it fit in with retrograde, where does it fit in with antegrade wire escalation. So remember this diagram from yesterday, and the four different types of approach, and in fact the way that we classify our CTO procedures: antegrade wire escalation, ADR, retrograde wire escalation, and retrograde dissection re-entry. And we've seen examples of three of those so far with AWE, ADR, and RDR. We haven't seen just a straightforward retrograde wire escalation. The limitations of antegrade wire escalation we're all aware of, whether these are people post-cabbage or not, and all the different adjunct strategies that we have to facilitate or to increase the success when AWE fails. And parallel guide wiring, IVUS guidance, well, yes, these were things which were extremely useful at the time when there wasn't an alternative available. But still, there are limitations of these adjunct antegrade techniques: parallel wiring, post-bypass surgery or no bypass surgery, still relatively limited success. IVUS guided wiring also, well, yes, it does work, but is it predictable and reliable, and is it successful most of the time? Of course, we need to be retrograde operators. If you're going to be a CTO operator, retrograde has to be actually at the forefront of what we do when you're making that transition from being what I would call a generic CTO operator to somebody who can do everything. But it's not always successful. And you saw that from the case yesterday, when you're presented with an option which previously looked like a failure, then take advantage of that new option. If you're in the subintimal space and you have a device to get you out of it, then use it. We've got a lot of experience now. This has been the registry that's been led by James with centres all over the UK, gathering data over the last half a decade or so, over 1,000 CTO procedures, more than 500 retrograde procedures, but really in this group, with a reasonable experience of retrograde, unable to get retrograde access in 1 in 4 cases, unable to complete in 18%. So antegrade wire escalation, absolutely, we must focus on those fundamental skills, but we have to accept that it's decreasingly successful with increasing complexity. That sort of seems self-evident. Retrograde, of course, yes, we have to do, but ADR, I would suggest, is a technique which fits into this range of complexities. The more complex the cases there are, the more options you have to have available. So if you're going to be taking on the most complex cases, it's not sufficient to be an outstandingly good antegrade wire operator and a retrograde wire operator, but you have to have, in addition, your dissection re-entry skills, which we've accepted we will develop with reverse cart and retrograde dissection re-entry. So I don't think it is a big leap conceptually to say Well, if we're going from subintimal space, retrograde, back into the true lumen, then why not do that antegradally as well? So patients with complex disease need alternative options for successful complete revascularization. So the myths that people still hold in their heads are that this is like STAR, subintimal tracking and re-entry. The difference is that you can target your re-entry zone, you're not losing the side branches. In case you saw yesterday, we maintained all the side branches. We had a fairly precise and controlled re-entry before that bifurcation, and so you maintain side branches. And if you can't maintain a large side branch, then you would not do ADR. You would use an alternative option. So that has to be your prime motivation is that contemporary ADR aims to revascularize every distal side branch. So where does it fit into our strategy? Well, if you're inadvertently in the subintimal space, which is the major mode of failure, that mode of failure now becomes a mode of success. So previously, if you couldn't get out of the subintimal space, you'd sometimes try and bail out if there wasn't a retrograde option, or perhaps if you weren't a retrograde operator, of trying to get back into the true lumen distally. But if you have a dedicated device which you can do that with millimetre precision, well, why not use it? When there is a very long and complex lesion, and we understand now when we're assessing these four components of CTO lesions, the cap, the lesion length, the interventional collaterals and the target, when you have a very long and complex lesion, but there is a good landing zone, you've got a target to aim for, there's no distal bifurcation, then ADR can be used as a primary strategy. So, you have a well-defined proximal cap, lesion more than 20, no major side branch or distal bifurcation, good landing zone, and obviously that's relative to your experience. The primary strategy there would be antegrade dissection re-entry, with bailout, retrograde if required. Now we'll have labelled this point, but the proximal cap we used to think, I think, was of prime importance in our ability to get into the vessel architecture. But as you'll have seen from the discussions about base and side base, even if you've got osteal occlusions, that if you can get into the vessel architecture, then in fact, then you can, once you're in the subintimal space, you have a way to get out of it. But this is the type of lesion where you can actually go up front with a soft wire, with a crossboss, you get straight into the vessel architecture, and you will either go straight through the lesion or you will end up in the subintimal space. So this would be an ideal scenario in every CTO, is that you're using this blunt dissection tool, the crossboss catheter would burrow its way through, maintaining an intraplaque position, and you then come out in the distal true lumen. Now this does happen more commonly in the LAD, which is in a straighter vessel in comparison to the right coronary artery, and that will probably occur in around 10 to 20% of cases. So here you've got James, about looking a bit younger, Simon Walsh, and you can see this anatomy here. It's not a particularly long lesion, and it's probably one that many of you would approach with antegrade wire escalation. This was in some of the early experience, and you can see Simon's moving his fingers pretty quickly. He's actually approaching the distal cap. Doesn't look like a particularly heavily calcified vessel. Continuing to, you can see his hands spinning away. So the tip of the, let's just play that again. The tip of the crossboss here is spinning very quickly. The friction is reduced, and it will act as a blunt dissection tool going through the lesion, maintaining an intraplaque position in this particular case, and there you see it's jumped through the distal cap into the distal vessel. And essentially in that situation it then just becomes a microcatheter, and you then have to change out. The position is good, and wire goes into the distal vessel, and that case is done extremely efficiently and quickly. And it may well be that with the shorter lesions you don't need that, but if you've got a lesion with a good tapered cap, a good target in the LAD, then a primary ADR strategy can be a highly efficient way of revascularization. But more commonly what happens is this blunt dissection tool, the crossboss catheter, will enter into the subintimal space. And as we've learned, once you're in the subintimal space, when you're adjacent to a good target, which you're identifying retrogradely, then you can re-enter that space using the other tool, which is the Stingray. And so you're able to position the Stingray balloon. Remember yesterday, we didn't use a crossboss catheter at all. We were there alongside the distal vessel, having got there with a gladius wire, and we were able to position the Stingray. We used a Miracle 12 as a stabilizing wire to deliver the Stingray balloon. Once the Stingray was in position, we're then able to puncture back in. And you could see the separation between the wire and the Stingray balloon. I think when we took that out of the patient yesterday, you could see that the exit of the wire coming out of the side of the balloon. Now, this seems simple. However, in the case yesterday, you will have noticed the patient was quite fidgety. Just at the crucial point, he decided he didn't want to be on the table anymore, and there was some movement. So that is made more difficult if your landing zone is compromised in some way, or there is disease within the landing zone. So that makes the ADR re-entry more challenging, but still possible. So let's go through a basic case. Again, we've got Simon Walsh here. So let's do our lesion assessment. So you've got a tapered cap there. Lesion here is about 25 to 30 millimeters long. There are interventional collaterals there coming from the PDA, filling the LAD distally. So we've got retrograde options. The target you see is very clear. You can see there is some disease in that LAD, but the pathway from LAD proximal cap to the distal target, so this is where you would be looking to re-enter. And you see that here. You're trying to make sure that you're landing in an area and re-entering where you're not going to remove a side branch. So, well-defined cap, more than 20, landing zone, no branches. This is a good case. So I think this case was done on a course by Simon in Belfast. So these are the interventional collaterals. These are a little bit tortuous. So absolutely, yes, there are interventional collateral options, but are these the most efficient way to achieve revascularization here, or would ADR be a primary strategy? Well, I think in this case, ADR is the correct primary strategy. So this is the way in which we've systematized the thinking. You all know this hybrid algorithm by now. Dual catheter injection, look at the cap, the target, the collaterals, the side branch at the distal cap. Are you going to go antegrade or retrograde? If it's antegrade and it's short, wire escalation, antegrade, longer than 20, dissection re-entry. And if it fails, then bail out to RDR. So this case is a good example of that. Cap is defined. The collaterals, because of some of the tortuosity, are potentially difficult, and there's no bifurcation at the landing zone. So remember, tapered cap there, crossboss is going in. Now it's been spun in. You can see the way in which the catheter has been spun very quickly, maintaining a sort of frictionless passage. Now the crossboss can steer off into side branches here, and you can see here as it's probably getting to bifurcation, it's now turning down following the course of the LAD. So we also saw this yesterday, the very nice profile view of the Stingray balloon. You have to be careful about the preparation of the Stingray balloon. Here we see it very nicely in profile. And so once that's all in position, this is now getting ready for the initial puncture. Balloon in position, you can see your distal target. There has been some shrinkage here of the target, so that it's not a huge target, but the proximity here of the balloon adjacent to the vessel, and so the Stingray wire is now being introduced. So here we are, now wanting to exit the balloon. It's around sort of 6, 7 o'clock. Now we don't know from this orientation which is the proximal and distal port and which port is which. So you have to try, you'll end up coming out one side and then turn the wire and coming out the other side. So there we are, coming out the right side, make the puncture. Now when we started, not quite a decade ago, we were using the Stingray wire to go into the far distal vessel, but we found that a less effective way and have now routinely swapped to using a Pilot 200 or a more lubricious wire to make that puncture. So the orientation of the balloon is very important. So you need to be able to see it in that nice profile view. The alternative is that you see the two wings of the balloon, and in fact you then can't make a judgment about whether the wire is coming out one side or the other. So here you see the wings of the balloon, here you see it in profile. And so really this is, when the X-rays shining on the balloon here, you're seeing it in this profile, so the wings like that. But in fact what you really want to be doing is shining the X-rays from the side in profile, and that's how it should appear. And you'll need to find that position where you've got your alignment of the target and the balloon in that correct orientation. So the puncture has been made by the Stingray wire. This is the same case being done by Simon, and he's now come back, I think, with a Pilot 200, so putting a slightly more acute tip on the Pilot 200 just to try and engage this side port, and there we go. So exiting the side of the balloon, coming into the vessel, then turning round, and now we'll be advanced, and here we are going into the distal vessel.
Jonathan?
Yeah.
One of the things I've noticed in my initial experience with this is that when you do the swap with the pilot, you think you're in the lumen again,
Yeah.
and you push and you dissect actually.
Yeah.
So what you've shown here very elegantly, you exit the port, you will go through the route of the Stingray wire,
Yeah.
pull it back very gently, and move it back into the lumen, drop it back into the lumen.
Yeah. But these are the types of fine wire movement and manipulation that we're all used to doing in antegrade wire escalation. Why not, treat it in the same way? I mean, these are small micro movements. We've got predictable behavior of the wire. We know what the wire looks like when it's stuck in the space. We can see it wrapping round. But there is a degree of tactile feedback and the visual feedback that you have to, and I think you just have to do it.
If you watch the way the wire flips over, so it comes out the board, so it's down towards 7 o'clock, and then it comes back, flips around there,
And drops back
drops
into
back in.
Yeah.
And that's when you know that you're back in. So when you see the wire, you turn it over, you tilt it round, pull it back, and you'll see it collapsing in. That's when you know.
And the reason why we've stopped using the Stingray wire is because the Stingray wire is a particular design. It has a 014 tip, but then there is a barb on it like the sting of a wasp. And so when it may be helpful in making the initial puncture, but if you've got a small target, a small landing zone, it will catch on the opposite side, and so it then becomes very difficult to advance. If we've got diseased landing zone, we will actually, I think most of us are now using CP12 or even a Stato 20s to get through calcium within the landing zone. So once the wire's in, typical sort of changeover, and the revascularization happens then in the conventional fashion. So in this case, very nice stent placement here in a relatively simple primary ADR case. But as we saw from the case yesterday, which wasn't quite as simple as this case we've seen, that it is possible to use and effectively deploy ADR and Stingray in much more challenging cases. So here is a very difficult sort of uncrossable cap, right coronary CTO, over 40 millimeters long, very good landing zone. Very good landing zone. So there is the potential for retrograde dissection re-entry, but the collaterals in this case are difficult. And if you make the judgment up front that the collaterals are going to be particularly challenging, then again, it is appropriate to go for a primary ADR strategy. So right from the outset, your case should be set up to allow you to perform ADR. So getting into the cap here was difficult. Lots of tricks and tips that I think you saw yesterday with trying to get into a challenging vessel, requiring side branch anchor or even rotablation into the subintimal space. So in this case, rotational atherectomy. And all this is really concentrating on is able to challenging the difficulty of anatomy of the proximal cap, getting into the subintimal space with the knowledge that once you're in there, you can make rapid progress, often around the CTO body lesion, and then re-enter in the distal vessel. So using knuckling to get to the distal vessel, you're using, oops, sorry, these aren't playing, knuckle wire maintaining the architecture. You then using cross-boss, once the knuckle's in a satisfactory position, get to the distal architecture, Stingray in position, stick and swap, Stingray deployed. And these cases really can be very efficient once you understand the sequence of steps that you need to do. So each little step is a challenge in itself. We saw that yesterday with James's case, and in the case that I was doing, that there were lots of little conundrums and puzzles at each point, but there is an algorithm to fix them. And so in these very complex cases, you can revascularize the right coronary artery in a very efficient manner. Even an osteal occlusion does not necessarily, in the age of complex ADR, mandate retrograde dissection re-entry. So the principle is the same. Somehow get into the vessel architecture. You don't necessarily need to be in the true lumen, but if you can get into the vessel architecture. So at this point, you think you're in the subintimal space, and you're pleased to be in the subintimal space, because then you can get a knuckle wire in position, The knuckle can advance safely. Now, for those of you who haven't done this before, you think this is not safe. And I think the first time that you do it, it's probably best that you do this with somebody who's done it before, present with you in the lab. But once you start doing this, and once you understand the properties of the wires will not allow you to exit the vessel, this actually becomes a much safer option than blind wiring with penetrative wires when you're not sure which space you're in. So the knuckle wire helps you get into architecture. Knuckle wire is in, you can then switch out to the crossboss. Use the crossboss to maintain a more controlled subintimal space, so not accumulating hematoma, which is one of the drawbacks of extensive knuckling. And again, stingray in position, nice position. You can see the wings in profile here. Yes, this is not a particularly attractive landing zone, but you can see the markers with the calcium. Probably in this situation, I would use a Confianza Pro 12 wire, directly puncture, and then go into the distal vessel. So we have to be backed up by some data. And at the moment, I think it's sufficient to say that there is no evidence to suggest that ADR leads to bad outcomes. And in fact, we've got to the point where, and this study is yet to be published, but is really, I think, an extremely important piece of data. I would say that because I've been privileged to be part of this study, being led by James and Simon Collum, and it's really a very strong piece of work looking at, I think, nearly 200 cases. This is a typical case included in the study. Bailout ADR after the antegrade wire ended up in the subintimal space. Here we are at 1 year. So there are 200 cases of OCT follow-up at 1 year. And the signal that we're getting from this data set is really astonishing in that vessels heal up in a remarkable way, whether you're in the subintimal space or in the true lumen, and with very good evidence from OCT that there is no adverse healing consequence of having a stent in the subintimal space. So the message really is that once you've got flow, then the healing begets re-endothelialization. So the flow begets re-endothelialization. The signal that we were getting, I think, is that there is an excess of events in retrograde dissection re-entry, and certainly in diabetic patients. But contemporary ADR is an extremely useful tool. It's been used in around 20% of cases, I think, in our experience, maybe a little more in some places. It's very controlled. I think it's reasonable to say now that it's safer and more predictable than complex retrograde. We're seeing that the outcomes in the long term are acceptable, I think excellent in some cases, and I think it's a very important part of the CTO toolbox. Thank you.